Now I would kindly ask all of the presenters to join me here for final words and the closing remarks in the panel session. Now, it is quite clear that this session raises a lot of questions. And regarding the position of radiology in a tumor board and general discussion with the clinician, it is quite obvious that already today we raised a lot of questions, starting from the question: are we dealing with a tumor or a pseudotumoral lesion, or are we dealing, if we are dealing with a tumor, how can we accurately grade it and establish the prognostic estimation for the patient? And of course, a very important question in a high-grade tumors: are we capable of dealing with the tumor with the monitoring of the patient, and are we capable of establishing the early signs and diagnostic signs and to bring up the diagnostic decision to change the therapy? Obviously, we are, though it is not always easy. So actually, since it is quite clear that the clinicians, the neuro-oncologists, the neurosurgeons and the radio-oncologists cannot do anything anymore without the radiologist in not only in a tumor board session but in a daily work. What is your opinion? Where this leads us actually? Are we going to change the structure of decision-making bodies in the hospitals? In some hospitals and in some countries it's already so, but what is your opinion? Shall we start with Pia?
Well, I must then refer actually to a lecture that I heard yesterday by Professor Turner, where she, of course, as being a woman, which we consider is important, put neuroradiology in the middle. So everything comes from the neuroradiologist, and in a tumor board, I think the neuroradiologist is a very important person. He could help not only the neurologist, but he helps the neurosurgeon how to select the area for biopsy. He certainly is helpful for the neuropathologist and then also in the follow-up. So I think, yes, neuroradiologist and neuroradiology and radiology should be in the center. And I think in most places, I think we are there already. I'm not sure, but I feel we are.
Yes. As in our clinic, we always discuss, of course, the cases with the neurosurgeons. But mostly, as far as I can see, they mostly focus on conventional technique, and they are not so much familiar with this new functional technique. And it's kind of excitement to make them familiar with such techniques, such as perfusion and DWI. And they are still getting surprised, and still there is a lot to discuss with them and to go further in terms of imaging. So they are still enjoying very much to discuss this new technique.
Yeah. I mean, I agree with the previous speakers. It always takes some time for the clinicians to catch up. They just about understand diffusion-weighted imaging, and then perfusion some understand. And I think the real challenge is that we already have so much information available. You know, if you give contrast and you do a dynamic contrast-enhanced DCE sequence, I think the real challenge is to extract all the information that we have, compute it, and then, as Pia has shown, if you actually combine the measures, so there is not diffusion versus perfusion and so forth, but get a multiparametric approach, I'm sure we could solve a lot of cases. The question is, how do we do that? How do we get there? And your multiparametric response maps, they are brilliant, but how do we get that into practice?
I would just comment on that. I think that at this very moment, a wide variety of new techniques that appear, and this is this covenant that we opened, this ARCO covenant that is this very moment in the neuroradiology hands, and this is technology. Actually, may lead us into this direction where we should feel the overload in a daily work, and if it is upon us to differentiate what is important and what is not important, I think that you raised actually the very important question: do we need all of these techniques, and is it possible to at this very moment to say, okay, most probably this will be sufficient for the treatment, for the monitoring of the treatment of the patient. But generally, if we start doing all of this stuff and performing it, then we will need a lot of time to decide what to do with the patient, and then we will spend a lot of time on one patient. And perhaps it would lead us in another way, where the neuroradiologists will burn out in a whole team, and the clinicians will just say, well, thank you. What do you think about it?
Well, I mean, first of all, since I'm coming from University of Lund, Sweden, we have a system where actually we as a neuroradiologist, we could decide what kind of protocol we want to do with or without contrast and which sequence we want to do. And we have many preset protocols. So for brain tumors, diffusion, of course, always included, and also perfusion. Spectroscopy is a little bit that sometimes maybe is not used by everybody, so that is maybe the one that I will put lowest on this scale. When it comes to the monitoring of a patient, at least. Maybe not for grading or for the initial diagnosis. What I think is important is if we're going to use these kind of techniques, there has to be a very fast post-processing program so that when we get the images to review them, everything is already post-processed and up there on the scanner and on the view box. And that's the case, at least at my institution. We get the perfusion maps, we get the diffusion maps, everything is pre-done. I don't have to sit and do it. Because if I should read 50 cases, I don't have time to sit and do it. It comes by the text. They do it very nicely and very good. And I think that is crucial to build that post-processing machinery in your team so that you get the images. That certainly will decrease the time it takes to evaluate them.
Yes, in our clinic, in our department, also we implemented both diffusion and perfusion in clinical workup of tumors, because diffusion weighted images just take 30 seconds to get. And for perfusion weighted imaging, we already inject the contrast material for imaging of conventional MRI, but it takes only 1 minute to get the raw data. And then if you have a good technicians, good residents, and yourself, of course, it's not that hard to get all those perfusion maps. In terms of ACL, we spend 5 minutes to get extra. So it depends if you are research-oriented or if you just don't want to use contrast enhancement as in the kids. So it can be excluded, but in our institute we use both technique to get more information comparing conventional MRI.
Well, Pia, you're very lucky. I have to do the perfusion imaging myself. And this is, I mean, the question is, perfusion is a bit more complex, and also training techs to do it is good. We have done audit of different softwares, and using the same perfusion data, putting through different softwares, getting completely different results, correcting for leakage and so forth. So it is complex. At the moment, I think that is the problem. I also have many colleagues who say, oh, perfusion, that's your specialty, and there are only a few of us who do it. Because if you are sort of counted by performance how much you report, perfusion takes a long time. My hunch is that probably if you set up ASL properly, ASL is going to probably increase. At the moment we do a triple perfusion, so we do DCE, DSC and ASL in the tumor patients, and we will audit it. But I wonder what you think, which of the perfusion methods will prevail?
So far, since we are doing a thesis and a research study, we both compare both technique. But I believe that according to your preference and according whatever perfusion method you prefer, you will select one of them. But because it looks like it's gives almost roughly the same sensitivity comparing to each other. But there are, of course, some details and some certain cases that you can prefer. of course, the best to get 3 of them. But again, as you said, that it's time consuming, and I believe that you will select one of them, according your case.
I guess that the most difficult thing would be to establish the definite level of accuracy and to define the space where we can trust to defining and where the clinicians can trust us upon it. But I think that since our time is slowly running out, I may say that we are fully agreeable that at this very moment there is one circle, and this is the neuroradiologist. Everything goes in and goes out from the clinicians and to the clinicians, and this is the fact at this very moment. Would it improve? We'll see. Thank you very much for your attention.
Thank you very much.
Thank you. You were great.